Okay, so now we have moved on to methods of assessing fetal status. Oops, what happened here? Oh, sorry. Okay. Methods of assessing fetal status and OB procedures. Okay, that's what we moved on to. So these McDonald's rule. So this is something we're going to learn in the clinical as well as lab. So McDonald's rule, no, it's not the hamburger. Make sure you have your patient void prior to measuring her fundus. That's what we're measuring. So we measure from the top of the suprapubic bone, and we have to palpate for the top of the fundus. So on the measuring tape, therefore, the centimeters would correlate to the gestational age. So if we measured and the measurement fell at her navel, mom's navel, let's say, that's approximate to 20 weeks gestation, which is halfway through the pregnancy because a full-term pregnancy is 40 weeks. So each week when she comes in for her visits or months or however long it is, we're going to measure her to make sure that the fetus is growing and progressing. Oh, my rooster's crowing now. Okay, so that fetal or McDonald's rule, that's one way we can check for fetal well-being. How well is this baby doing? Does it continue to grow? He got his crow stuck now. Okay. So oftentimes we'll get where mom will call in and say, I haven't really felt the baby move today. And oftentimes it's because, well, maybe she's just busy in the course of a day. She hasn't really paid attention. So we might have her lay down, preferably on her left side, and at the same time every day, count the number of fetal movements in every 10 minutes. So we might, if she did it in the morning, we want her to do it the same time the next day. We want her to have at least 10 movements, okay, in an hour, 10 to 12. And if she doesn't, then one of the things that I would tell her to do is to drink something or eat something and do it again, because moms are always very busy and don't often take care that they have drank or eaten anything throughout the day. So that's another way we can assess fetal well-being. Reasons that we want to monitor this mom a little bit more: if there is decreased fetal movement, if she has what's called an elevated maternal serum alpha fetal protein level, and that's a test that's done early in the pregnancy. If she has any bleeding tendencies or complications there, any fetal heart rate problems, infections, maternal disease like diabetes, thyroid, high blood pressure, pregnancy-induced hypertension, okay, then we want to watch this infant a little bit closer and have her come in and do more frequent testing on her. So fetal monitoring. Monitoring can be done uh, on a machine where we hook her up to it, and we would do what's called a non-stress test where we monitor mom for 20 minutes and we look at the fetal heart rate, how are things going. So we would look, maybe have her come in once a week or twice a week depending on what's going on with her, to look at the fetus and how well it's doing. We look at the fetal heart rate is within parameters where it should be, and is there variability. So we talk about that later too. So there's different ways to monitor, not just hook the mom up and have her lay in the bed and hook to this monitor. What's called intermittent osculation, and what this is, if you were, when you were in 111, if you couldn't get a pedal pulse, you would use a Doppler a handheld Doppler to find the pedal pulse. Well, the Doppler, how it's used in maternity, is to find the fetal heart rate. So it's a handheld device that can be placed on mom's abdomen, and there's a process of doing it to look for heart rate. Electronic is where we have her lie in bed, we put the straps around her and hook her to the monitors. So for a 20-minute non-stress test. Fetal blood sampling can be done as well. It is for acidosis or alkaline. Fetal heart rate response to stimulation. I'll talk about that. Um, I got a little pet name. I call him Frank. He looks like a razor there on the left of the bottom. You put that to mom's abdomen, and baby kind of jumps when he feels the vibrations. Oxygen saturation and cord blood sampling are different ways that we can determine fetal well-being. So, unfortunately, students don't get to go to community day, and so we don't get the activity of feeling mom's abdomens and fetal. You can actually palpate and feel fetal position and presentation, and this is called Leopold's maneuver. We would feel for where's the head located. It feels like a round area. The back feels like a C, so you can feel where the back is. Unfortunately, I wish we could do that. If vaginal exam, if the mom's in labor, we can palpate the sutures at the top of the head to determine what position the fetus is in, whether it's anterior or posterior. And an ultrasound is another way that we can determine well-being. So as I already said, intermittent oscillation is we look, first we want to determine where the fetal back is, because if we palpated the fetal back, that's about where we would look for the fetal heart rate, okay? And what is the fetal heart rate? Fetal heart rate should range anywhere between 110 and 160. We get to that in greater detail later. And as I said, a handheld Doppler can be used. So we look for the fetal back, and we have to use a gel to put on the Doppler for conduction and determine what the fetal heart rate is. Okay, those are different ways that we can do it. Also, if mom's in labor, we can still use intermittent osculation, but you'll find that, and usually we use that if mom doesn't want to be hooked up to the monitors. But patients often don't know that they can refuse to be hooked up and tied to those monitors, and we can use intermittent osculation. If she's in early labor, in other words, she's only 1 to 4 centimeters, we might just get a heartbeat every hour. If she's in true active labor where contractions are coming more frequently, then we would probably get a heartbeat, as it says here, between contractions and at the peak of the contraction to determine what the fetal heart rate is. So non-stress tests, again, monitoring for fetal well-being. We might have this mom come in. She said, "Well, I did my count on the fetus, and baby's still not very active. So we'll put her on this monitor, and the monitor does look like that. You'll see them in labor and delivery, where we determine what the baseline is. We monitor baby and mom for usually about 20 minutes. Okay, and that's a process that you will learn as we proceed and progress. A non-stress test, it's called. She's not under any stress. We're just having her lie there. So let's say the provider has decided he's going to bring this mom in for an induction of labor. Well, we want to see how well this baby does this fetus does while she's being induced. And some fetuses can tolerate induction and some cannot. So again, it's sort of like a non-stress test. We put her on the monitors. However, we hook her up to Pitocin for 1 hour to see how the infant does with the contractions. And if the infant does fine, with no complications, no problems, okay, so we're going to set her up for a different time to come in for induction. If it doesn't, then she may end up having to be signed up to come in for a cesarean section. So again, fetal well-being. So electronic fetal monitoring is external. In other words, we put straps around mom. Okay, there's an external and an internal. So let me talk about the external. Toco. Okay, so this is actually the toco here, which matches over here. And we palpate for the top of the fundus, and that's where it is applied with the straps holding it on. And it picks up contraction pattern. And this is just, well, how should I say, it's not always accurate. It's a guesstimate. And so oftentimes I don't usually, if the mom is actually in labor, I won't watch the monitors. I'll ask the mom. It's more accurate to ask the mom about her contractions and to palpate them rather than just look at the monitor. So this one here, over here is actually the ultrasound. So it picks up the heartbeat. So we want to palpate for the fetal bag and put the gel on, so our conduction material, so we can get a fetal heart rate. So these, as I said, are external. That's one way we can monitor fetal well-being. This is just a look at, without going in detail, because we do have a lab that we do that with, about talks about non-stress tests. So external fetal monitoring. So the ultrasound goes to the fetal back. Okay, so we could pick up the heart rate. And the toco goes to the fundus of the uterus. And the straps are what holds it on. A 20-minute strip, a non-stress test. Okay, but then we also have what's called internal fetal monitoring. We would use internal fetal monitoring if we thought there was a question about the fetal heart rate and what's going on with the baby. Or internal fetal monitoring can also be used to pick up contractions. Intrauterine pressure catheter is what IUPC stands for. So it can monitor things more accurately. So like a fetal, what happens is, in this next picture I'll show you, so the monitor goes, I can't see, I got my glasses on. The intrauterine fetal monitor has got like a little spring, sort of like, you'll get to see it in the lab. It looks like a spring that goes on in a pen. And it goes on the top of the fetal head. So no matter where the fetus moves or how it moves, that monitor is attached. And then we have a IUPC, which picks up contraction that lays along inside of the uterus against the fetus in the abdomen, and gives us a more internal monitoring, gives us a more accurate picture of what's actually going on. Okay, so that's why the provider might want to use it as well. So things we look for, and I'm going to talk about this later, so don't rack your brains about it right now. Baseline fetal heart rate, tachycardia, bradycardia, variability. So tachycardia and bradycardia, you should know those. A fast heartbeat, a slow heartbeat. We have a lab that's all about that I'll teach you about later. So there are different aspects of a non-stress test that we look at. So I'm going to kind of like skip over this part, even though you can read it if you want to take the time, and we talk about it in more detail in one of the labs that we have, okay? Again, these are different strips and what they look at. you're still early here in the program, so like I said, don't rack your brains about it. We'll cover it in great detail. So we have different things we look at: late decels, variable decels, prolonged decels. These are things all that you can see on the monitor strips. So fetal well-being, that's what we've been talking about, can be measured by response of the fetal heart rate to uterine contractions. So either they're good, which is called reassuring, or they're not good, non-reassuring. So as I said previously, reassuring, okay, we're going to set you up for that date of induction, come in and bring you in because everything looks good. Or non-reassuring, no, I don't think so. We're going to set you up for a C-section because this baby isn't responding very well. Okay, so different parameters that we will be looking at, and those don't apply to you right at this point in time, please. So don't stress yourself out here. Okay, so then we're going to go to OB procedures. I already talked about a non-stress test. It's a test that's done for 20 minutes from the beginning of the test. Now, sometimes we end up leaving mom on longer. What's a reactive stress test? And ignore the pages there. It's different. The reactive test would, there's accelerations. Baby's moving. The heart rate is accelerating and it goes back to baseline. So that's a good thing. But a non-reactive stress test, it does not. So we want to get at least 3 reactive moments in a 20-minute strip. That's reactive. Or a non-reactive, no, it doesn't do that. A non-reactive stress test, then we'll send the mom for further testing, what's called a biophysical profile. Okay, the provider will do that. And, whoops, sorry. A biophysical profile, I thought I had it on here, I guess not. We'll look at, sorry for I keep clicking here. Lost my place. Okay, let's see. Biophysical profile will be done. Okay, so a biophysical profile will look at things like, is this what's the heart rate? Is there respiratory? It looks at different parameters to determine the well-being of this infant. How is it doing? Of course, this is a contraction stress test. So contractions, what happens is we'll put the mom on oxytocin, run it through an IV, um, and we want her to contract every 2 to 3 minutes for 1 hour. Okay, another way to make contractions is to have her roll her nipples, because there's nerves that run from the nipples to the uterus that cause contraction. Stimulation is what it's called. So we want her to have this number of contractions. So we won't want to do it prior to 28 weeks. No, because that's not a good thing. But is the contraction stress test negative or positive? In other words, she's good or she's not. That will tell us more information. There we are. The biophysical profile, that's what I was looking for. Breathing, movement, body movement, amniotic fluid, fetal heart rate activity. So it looks at those parameters. And if it's a 8 or to 10, that's okay. So she's fine. But 6 or below, oh, there's a problem here. So we can't do that induction. And that's not the only time that the biophysical profile can be done. If the infant's not growing, the provider might send mom for that biophysical profile. Okay. So if you do it too early, the non-stress test, that's not going to be reactive at all. You don't see a whole lot of movement there. Let's see. Vibroacoustic stimulation, and that's what I call Frank. He looks like a razor. Okay, that's what we used to call him. We gave him a name. If baby's not moving, mom comes in, will turn Frank on, and it actually is a razor, and put it to the abdomen, and it will cause baby to jump, and you help it to move. It's sort of like somebody jumped out of the box and scared you, and so we'll monitor that. If there's no movement, obviously that's a serious issue. Ultrasound, oftentimes we just send ultrasound mom early in the pregnancy for confirmation of the pregnancy. Infant's not growing, we might send mom to so that measurements can be obtained. If there's a problem with the fetal heart, we're thinking we can send mom for ultrasound then as well. Any anomalies, we can look at where was that placenta implanted. We want it to be on the upper outer wall, but maybe it's not. Maybe it's down at the vaginal opening, which would not be a good thing. So there's various things that we can send mom to ultrasound for. This is just an ultrasound that shows. So amniocentesis is also it shows fetal well-being, and basically it's a very thin hair-like long needle, because I had it done with one of my pregnancies, that's inserted through the abdomen to get a sample of that amniotic fluid. However, they need to do it with ultrasound to make sure that they don't hit the infant. And one of the problems with, yes, it can hit the infant. Mom can have hemorrhage if she's Rh negative. Want to make sure she gets ROGAM at the time. It can also send her into preterm labor or even infection or rupture of membranes. So there is a risk that's involved with this. So maybe DNA, we want to see, are there complications with this infant? Because there are um, histories that run in the family, cardiac anomalies or something, and we want to check. Late in the pregnancy, what we want to check for is fetal lung maturity. Remember earlier I said just because it's a big baby doesn't mean that it's okay? Well, with those LGA babies, what we find is that they're very large, but maybe they're very large at 35, 36 weeks, and the lungs in an infant don't actually mature until 37 weeks and beyond. So if this baby's, let's say, example, 10 pounds, and she's only 35, 36 weeks, we don't want to deliver it until we know that the lungs are mature. And so what we look at is the surfactant in the lungs. If the lungs are mature, we can deliver the infant. If not, we'll have to wait. And of course, at that point, mom might end up being C-section. So these are things that it can test, okay? Um, Tocolysis therapy, if mom's prior to 37 weeks, we don't want her, we don't want her having contractions, because that's called preterm labor. So we can use medications like terbutaline. Terbutaline is actually a respiratory medication, but it is also a smooth muscle relaxant, and it can be given PO or IM, or not IM, sub-Q, sorry, sub-Q, and it can stop contractions. Magnesium sulfate, another medication as well, which is usually given IV, can also stop uterine contractions, because we don't want her to deliver too early that may present with complications for the infant. So maternal positioning, that makes all the difference. If you're taking a blood pressure on your patient, make sure that you have her lying on her left side, because the weight of the fetus um, leads with when mom lays on her back, the weight of the fetus compresses against the vena cava, which can actually decrease the blood pressure. So we want her to be on her side anytime we take her vital signs. Okay, so maternal positioning makes a huge difference, especially blood pressure. So AFI, amniotic fluid index. Well, remember that infant is growing in a bag of water. So think of that bag of water as the ocean. If there's lots of water, then you can float in the ocean really well, and the arms and the legs grow symmetrically. Okay, but if there's very little water, that's a problem. Okay, so with things we see like with decreased amniotic fluid are clubfoot, for example. So a trained for professional, if you have to have your AFI or amniotic fluid index done, you'll go to ultrasound, and that's where they do it. And they look at each of these four sides, and they're looking for pockets of water for measurement to look at what is your fluid index. And maybe you thought you broke your water, but you weren't quite sure. That would be a reason to get an amniotic fluid index as well. So this would be considered normal, obviously, borderline, or abnormal. So look at the parameters. Here we go. Okay. So MSAFP, maternal serum alpha fetal protein, usually it's an early test, and it's done between the 15th and 20th, 20th week. Some moms refuse this. It actually detects neural tube defects such as like spina bifida, what they say here, Down syndrome, and other abnormalities. If oftentimes you'll see that moms might refuse this because she had it with her first baby, and she refused it with her second or third or whatever, or she came late into the pregnancy. She was 30 weeks, so she wouldn't be having this done. Okay. And then there's the triple screen, look at HCG levels. It's a screening test. That's all. It may lead to further tell you if there are complications. So HCG, remember we can test that in urine and blood. And let's say mom was pregnant and it showed that she was 6 weeks along. Well, she had some bleeding. The blood test showed she had that she was, it still showed 6 weeks. She just had started having the bleeding today, but doc told her come back next week and go home on bed rest, and we'll see what your levels do. Well, it had dropped, so she could be a potential miscarriage, spontaneous miscarriage. So that's what HCG can tell us. And remember that seed that was implanted early in the pregnancy? Well, that's actually called the corpus luteum. And so what happens is, if the between that 6 and 8 weeks, remember the placenta takes over, and if the placenta is unable to do that, that's typically when you might see a miscarriage, when in the HCG levels will start going down. Okay, if she's deficient in usually progesterone. Okay. So, if we've tested mom and found that she's deficient, she may need a progesterone suppository, is one way that they can give her to maintain the lining of the uterus so she does hold on to that pregnancy. There we go. Other hormones, know that. Other available tests, we talked about amniotic fluid, RH, what that means, and I'm not sure if you learned about that previously. You need to read about it in your book. It's very important. You may be giving moms um, ROGAM, which is what the RH is. Mom is RH negative and the infant is positive. If mom got into, and let's say she fell down the stairs, or she slipped on the ice, or she got into an accident, she would need a ROGAM shot. So she did not build up antibodies or an immunity or antibodies against the pregnancy. Because if she builds up antibodies, then that would cause her to abort the pregnancy. So fetal maturity, that's where we talked about amniocentesis. LS and PG, that's the lecithin to Spigmalion ratio. And what that is the surfactant in the lungs, and you need to have surfactant to keep the lungs open at birth. If this infant does not have developed lungs, then when he takes his first breath, the lungs will collapse because there's no surfactant in there, the sudsy material that um, keeps the lungs open. Okay, so you can read about each one of these, would be important. So these are some nursing diagnosis, electronic fetal monitoring. That's what that's called there. So a lot of times the patient comes in the hospital to be monitored. We're presuming that she's had this done before, and that may not be the case. And even if she has had it done before, has anyone ever explained to her what it includes and what it's about? So anytime you're doing, whether it's internal or external, you want to educate your mom about those things. And with the internal, as it says here, the transducers, the um, is the ultrasound one is attached to the fetal head. So yes, there's always a risk for injury, and the IUPC lays along inside the uterine cavity, so we run the risk of rupturing the uterus when that's placed. So yes, there is risks and concerns. So always and first most, if I have said from the beginning, educate your patient. Educate your patient on what the procedures that you're doing are for and what they're about. Okay, this just shows a fetoscope. And this used to be through bone conduction the old-fashioned way. Oh, okay, now they're noisy.